Hello friends, welcome to yet another intriguing edition of Rahul's Advanced Biology. Today we'll be talking specifically about a very intriguing topic known as the sinoatrial and the atrioventricular block in the human heart, in the conduction system of the human heart. Now I'll be commencing this specific USMLE lectures which would really assist the budding doctors to clear the USMLE Part 1 exam, to crack this examination and they can achieve their dream of practicing in the United States. Now, commencing with our topic, SA block and AV block. Now, before talking about the blocks, one should be very thorough with the EKG or the ECG analysis because that will let you differentiate between a specific block or flutter or atrial fibrillation or ventricular fibrillation, or we can talk about the premature atrial contraction. So we have to know certain criteria in order to discern that specific ECG pattern and to evaluate it and to then come to conclusion whether it's a real block or EAC or AFib or VFib or flutter or right bundle branch block or left bundle branch block and so on, right? So there are certain steps that I'll be equating you with. First is whether P waves are present. If P waves are present, then how many P waves are present in a specific strip? Then, if the P wave pattern is regular or not, means the time limit between the PP interval is same or is it varying? Then whether R wave or the QRS complex are present. If yes, then how many? And if QRS complex, if it is present, again if it is regular or not. If it is regular means there is no dropping of QRS beats, there is no drop in the R. So we need to check that out as well. And then we need to measure the RR interval, the successive interval between the two consecutive R waves and also the width of the QRS complex. Now, commencing with our discussion regarding the sinoatrial or SA block, sinoatrial node block, SA block, you can say that it happens in pretty rare cases. What happens is the impulse from the SA node itself is generated but is blocked before it even enters the atrial myocardium or the atrial muscle. Now what happens is the P wave gets seized and the resultant atria comes to a standstill, you can say. But the ventricles, however, we have seen that it has been seen that the ventricles pick up a new rhythm, right? And the impulse usually generates spontaneously in the atrioventricular node. So why can it generate in the atrioventricular node? The AV node is the AV node, the AV bundle, or also known as the bundle of His, and the right and left bundle branches, the Purkinje fibers. They're also the pacemakers. They have also the natural tendency of automaticity, the autorhythmic fibers, but they're kind of weak with comparison to the SA node. So I'll be talking about the intrinsic conduction of the sinus rhythm and the nodal cells in one of my next videos where I'll be describing to you about the T-type calcium channel, L-type calcium channel, the funny sodium ion channels, okay, the specific types of, you can say, the intercalated discs that are present, the desmosomes, then the gap junctions made up of connexons and connexin proteins and all that things. So we'll be talking about all those things, but just for now know that the AV node can take over in case of SA node failure. So the rate of ventricular QRS-T complex is slowed, but it is not otherwise altered. And sinoatrial block can also occur due to, you can say, myocardial ischemia, infarction, which affects sometimes the SA node, then inflammation or infection of the heart, or side effects from certain medications, and it can also be observed in well-trained athletes. So let's have a look at the ECG or EKG strip of an SA block or sinoatrial block. What you see here is you have a P wave, then you have a QRS complex here, then you have a T wave, then there is sudden cessation of P wave. There is no P wave here, you can see. This is the exact way to locate the SA block, right? P waves are disappearing. They are ceasing to exist. There are QRS waves. So you can see from that criterion perspective, there are QRS complexes. Okay. So the QRS complexes are also regular. If you have continuous SA block here, the time limit between the two QRS complexes like this and this are almost the same. But the thing is, the P waves are not regular. You can see P waves are not regular. And again, what you have is we don't have the P waves originating in many of the cardiac cycles. So that is the main discerning point of the SA block. Now coming onto the atrioventricular block. Now AV block, if we talk about, what happens in AV block is there are specific areas, or I should say there is only one specific area whereby the impulses can ordinarily pass from the atria into the ventricles. And that area is known as the AV bundle or the bundle of His. Now, specifically, many times you may be hearing that it's due to the AV node mismatch. It's not. It's due to the AV bundle or bundle of His. The conduction between the SA node to AV node and to the bundle of is blocked because it's the bundle of His which takes it to the ventricles, to the entire conduction pathway, the nodal cell. Now, what happens is, I already told you that the impulses are not received, or we have some kind of delay in the reception of the action potentials at the AV bundle. It is also referred to as bundle of His. Now we have multiple types of AV block, right? We have the first degree AV block, where the impulses generated in the atria are conducted to ventricles. They are conducted, but with certain delay that we'll talk about just in few seconds. Then we have first degree AV block, and then we have the second degree AV block. In case of the second degree AV block, only few impulses which originate in atria are eventually conducted to ventricles. Means not all impulses that originate in the atria are conducted to the ventricles. And then we have the most dangerous, the third degree AV block. Before we talk about the third degree, we have certain criteria or certain, there are two types specifically, the Mobitz type 1 second degree AV block and the Mobitz type 2. The Mobitz type 1 is also known as the wonky back AV block. And then we have the third degree AV block. So in case of third degree, which requires some medical intervention, which is a real high level medical emergency, not a single impulse which generates in atria are conducted to ventricles. Here what happens is the ventricle and the atria, they beat independently. There is a kind of AV dissociation one can think of. Okay, so let's talk about the first degree AV block. Now, in case of first degree AV block, we should know one thing, that the usual lapse of time between the beginning of the P wave and the beginning of the QRS complex is about 0.16 second, or you can say 160 millisecond. When the heart is beating at a normal sinus rhythm or normal rate. This is also known as the PR interval. Now, the PR interval usually decreases in length with a faster heartbeat and increases with a slower heartbeat that we all are aware of. In general, when the PR interval increases to more than 0.20 second or 200 milliseconds, the PR interval is then said to be a prolonged PR interval, and the patient is said to be having or developed a first degree incomplete heart block. Meaning that you can check here. In an EKG strip, these small boxes, they mean 40 millisecond or 0.04 second. So in one big box, you have 5 small boxes. So that makes up 0.2 second or 200 milliseconds. So we can just measure the length of the PR wave or the PR interval. Means How to measure it? The best way to measure is we take we take the point from the origination of the P wave and we end it at the origination of the R wave. Sometimes the Q wave is not seen in an ECG because Q waves represent the septal depolarization and are very weak. Sometimes they are not picked up by the galvanometer. So what happens is we have the R wave, which is the main ventricular depolarization. Okay, so we have the R wave which is picked up, and then we can measure the time limit or the difference in time period. So how many small boxes are present? 1, 2, 3, then 4, then 5, then 6, then 7, then 8. So one small box I told you is of 0.04 second or 40 milliseconds. So we have into 8, 0.04 into 8 is 0.32 seconds. Or I can say 320 milliseconds, which does exceed the 200 millisecond math. So this is known as the first degree AV block. Okay, this is the lead 2 of the ECG. Now, what happens is the interval, it goes till 0.32 like that, but it rarely goes. Okay, it seldom increases above 0.35 to 0.45 seconds, because by that time the conduction through the AV bundle is depressed so much that conduction stops entirely. Okay, so one means of determining the severity of some heart diseases such as the acute rheumatic heart disease is to measure also the PR interval. Now let's talk about the second degree heart block. Type 1 Mobitz or Mobitz type 1, because I told you early on only there are two types. Some people may call or classify it into three types: Mobitz type 1, Mobitz type 2, and then 2:1 or 2:1 heart block. So I like to do it in two ways only. So Mobitz type 1. It is also known by the name wonky back, okay, type of heart block or second degree heart block. So in this thing, what happens is when conduction through the AV bundle is slowed enough to increase the PR interval in a range of 0.25 to 0.45 seconds. And in this specific case, what happens is the PR interval has increased, but it increases in each cardiac cycle progressively. And then you see a drop. And then you see a drop of the R wave or the QRS complex. So that is what you should be knowing. That is what is the discerning point between the Mobitz type 1 and type 2. In Mobitz type 2, the PR interval is more than 200 milliseconds, but it does not increase progressively, and again the dropping of the R wave or the QRS complex happens. But here we can see that, you can see here the length of the PR wave. Again, the length of the PR wave here has increased. You can see the subsequent cardiac cycle, the subsequent PR waves are increasing in length. They are lengthening. Again, you can measure this with this one. It has again increased, and then we see a sudden drop. Okay, then there is no QRS complex, there is no R wave. Okay, here we had R, here we had R, here we had the R wave, there is no R wave. We see a sudden drop of the R wave, the flatlining here. Okay, so if we match with our criterion, does P wave exist? Yeah. Are P waves regular? Okay, so we have to think about the perspective that are P waves regular? So it just differs. It is not quite regular. I can say it just is little bit irregular if you measure the time interval, and we have the dropping of the QRS wave, R wave. So the R waves are not regular here. You can check R to R if you measure via caliber or even the paper method, the time interval R to R interval, R to R interval. Suppose these two are same, but these two, this is more because there is a dropping here. Okay, so R to R is not same. We have a dropped QRS here. Okay, so the thing is, in that criteria which I let you acquaint with in the first slide, here the R waves are not regular. Okay, and the PR interval is also kind of irregular here if you measure with extreme accuracy. And then we come to specifically the second degree heart block, Mobitz type 2. Okay, this is not the wonky back one. Here what happens is, you can specifically look at this EKG pattern again lead to that the PR interval is not increasing progressively. Okay, the PR interval is not progressively increasing. So what's happening is the PR interval is more than 200 milliseconds, and after some cardiac cycles, all of a sudden the R wave drops. Okay, the QRS complex drops. Okay, so here the P waves are regular if you put in that criteria. P waves are present and are regular, meaning that if you measure via caliber or the paper method, the difference between the two P waves, the PP interval, okay, they are kind of regular. If you do not take this one, if you take this one, the PP interval is regular. You can see here the P wave, okay, the QRS, the P, okay, P, again this P, okay, then this P again. So P waves are regular, you can say P waves are regular, but Q pattern, if you see the QRS, the RR interval, R2R interval, again here R2R, this will be extremely long or much longer than this R2R interval. So this R2R interval is not regular, okay, because you ever dropped QRS wave, it is not regular. Whereas this P wave pattern here, okay, this P wave, P to P, P to P is regular, P to P is regular here, okay. So what we have is number one, the PR interval, the PR interval here, the PR interval here, the PR interval here, they are not lengthening, okay. In case of the wonky back one, the Mobitz type 1, the PR interval or intervals were lengthening in the successive cardiac cycles, and then we had an R wave drop. Here the PR interval is not lengthening, and then we have a specific cardiac cycle where the R wave is being dropped. Okay, so this is the specific way to locate or to know, to evaluate and come to the conclusion that a person is suffering from, you can say, Mobitz type 2. So in type 2 block, there is usually a fixed number of conducted P waves for every QRS waves. So here only we can think of as there is a 2 to 1 block, which implies that there are 2 waves for every QRS waves. At other times, there are rhythms of 3:2 or even 3:1. Okay, so that could be there. Now type 2 block, okay, or second degree block is generally caused by an abnormality of the bundle of his Purkinje system, and it also may require implantation of a pacemaker to prevent progression to complete heart block and cardiac arrest. Now we come to the complete heart block, the complete AV block, also known by the name third degree AV block. Okay, so when the condition causing poor conduction in the AV node or AV bundle, it becomes very severe. The complete block of the impulse from the atria into the ventricle occurs. In this case, the ventricles, they spontaneously establish their own action potential because they have the capability of autorhythmicity. It can originate then where? Most likely in the AV bundle, but also could originate in the AV node. Okay, so it can originate, you can say, in the AV node or AV bundle, where? At which part? Distal to the block. Now the P waves, they become completely dissociated. Okay, they are present but and regular. R waves are also present and they are regular, but the P waves become dissociated from the QRS-T complex. Okay, so you can note here that the rate of rhythm of the atria is much more than the rate of the ventricle because atria have a better atomicity. Okay, so the both the rates will never ever match. Okay, so you can have 100 beats per minute the atrial depolarization rate and 40 beats per minute of ventricular depolarization rate. So you can say that there is no relationship between the rhythm of the P waves and that of the QRS-T complex because the ventricles have escaped from the control by the atria and are beating independently on or at their own, you can say, or on their own with their own natural rate. So that is controlled most often by rhythmical signals generated distal to the AV node or AV bundle where the block is really existing. So we can see here that the P waves, okay, they are present and they are regular. You can say the PP interval is constant. Also, the RR interval is constant. That is the best way to discern, to differentiate between a Mobitz type 2 and specifically the complete AV block. Sometimes what we can have is the R wave can also superimpose on the P wave. That can also be the case in some patients. So you need to be careful. But the thing is, the RR wave you can check here. The RR intervals are constant. Okay, so R waves are completely regular here. So that's the most important descending point, differentiating point in order to recognize the third degree AV block. And they are completely independent of each other. The atrial sinus rhythm and ventricular sinus rhythm are completely independent and they are having their own unique values with ventricular sinus. You can say the sinus rhythm is obviously much lower than the atrial sinus rhythm. And now we can talk about the etiology of the heart disease as well. So what happens is one can have infarction or ischemia, okay, which might have affected the AV node or the AV bundle, that is the bundle of his, okay, that delays or blocks the conduction from atria to the ventricles. Then one can also have had the compression of the AV bundle by development of the scar tissue, which might have generated due to the infarction or calcification as well. If you've had vitamin K2 deficiency, then we can have something known as the increased vagal tone. Now, what we have is that increased vagal tone can cause bradycardia, right? Like any circulatory reflex that stimulates the vagus nerves, it causes release of acetylcholine at the vagal endings in the heart. We are all aware of that. That is known as the parasympathetic nervous system. Now, the most striking example of this phenomenon that is asked in the USMLE examination occurs in patients is known as the carotid sinus syndrome. In this, in these patients, what happens is the pressure receptors or the baroreceptors in the carotid sinus region of the carotid artery walls are extremely sensitive. They become really, really sensitive. So what happens is even a mild external pressure on the neck, it elicits a strong baroreceptor reflex, which causes again intense vagal acetylcholine release, and which then affects the heart and can cause extreme bradycardia. So sometimes this reflex is so powerful that it actually stops the heart for 5 to 10 seconds, leading to loss of consciousness or syncope as well. Okay. So then we can have something known as endocarditis, myocarditis, that is the inflammatory diseases that can cause all this, and also infiltrative diseases like amyloidosis, lymphoma, also some kind of congenital heart disease, also maybe lupus, which has been passed from the mother due to genetic, you can say, variation or mutations, systemic lupus erythematosus. Then again, AV conduction system degeneration could have occurred as well, which is mostly seen in older patients. And then inflammation of the AV bundle or bundle of his could be another, you can say, cause, or even inflammation of the AV node. Okay, so extreme stimulation by the vagal tone that I told you. Yeah, I have told you. Then we can have the medications like the beta blockers, the calcium channel blockers, the digoxin. Okay, that can also impair AV conduction in some cases. So that's about it. That's all the conceptual prowess we need to attain in order to understand and comprehend, decipher this lecture. If you like this lecture, if you like the quality of the lecture, then kindly hit the like button and also subscribe to my channel, Rahul's Advanced Biology. And if you've had any kind of queries or questions, then do not hesitate to post your queries, post your comments in the comment section below. I'll be replying to your comments as soon as possible. You can also like my Facebook page, Rahul's Advanced Biology, and directly you can contact me via Messenger app as well. So thanks a lot. Let's meet you in the next lecture.